October is Breast Cancer Awareness Month, and so I'm going to be just talking a little bit about breast cancer, some of the risk factors, and screening, and I hope that it will be helpful. So breast cancer is very common. It is the second most common cancer to be diagnosed in women. I would think that almost every woman in this room would know someone whose life has been touched by breast cancer, and probably men as well, because about 1 in 8 women will receive a diagnosis of breast cancer at some time in their life. It is also the second most common cause of cancer deaths in women, so definitely very important. In 2018 alone, over 260,000 new cases of breast cancer were diagnosed, and that resulted in approximately 40,000 deaths. The good news is breast cancer mortality rates have improved, so they've decreased over time. Now, women who have a diagnosis of breast cancer have about a 5-year survival rate of 90%, comparatively to the 1970s when that was about 75%. So this is really attributed to earlier diagnosis from improved screening, as well as improved treatment modalities for women who are diagnosed. Currently, there are 3.5 million women in the United States living with breast cancer. The risk factors, some of the risk factors we just cannot change. So the biggest risk factor for breast cancer is being a woman. The other risk factor that we cannot change, unfortunately, is advancing age. Better than the alternative, but the older we get, the bigger our risk for breast cancer gets. Other things that we don't have control over are family history, radiation exposure, primarily radiation exposure with regards to childhood lymphomas, and other cancers. Breast density, so women with dense breast tissue have a higher chance of getting cancer, ethnicity, and also the age of menarche and menopause. Some of our modifiable risk factors, or risk factors that we can kind of adjust for ourselves, is nulliparity. So women who have babies are actually at a decreased chance of having breast cancer. A prolonged interval between the time that you first get your period and first have your first child, the increased length of that period is increased the risk. Using postmenopausal hormone therapy, particularly in women who use estrogen and progesterone therapy, has been linked to a slight increased risk in breast cancer, although this risk is very small. Also, as you can see our little picture, alcohol consumption, smoking, and a higher BMI have all also been linked, so good things to avoid for many reasons. Breastfeeding decreases your risk of breast cancer, so another good reason, another good benefit from breastfeeding. Things that don't, just want to touch kind of lightly on this. A lot of people have heard one of these kind of commonly circulated myths. Antiperspirants, bras, induced abortions or terminations, breast implants, the HPV vaccine, and breast size all do not affect your risk of breast cancer. One of the big pushes with for recognizing kind of your own risk for breast cancer is what we call breast self-awareness. And part of that includes knowing your own family status and being able to kind of assess your own risk status. There are several different ways to do this, and there's some mathematical models. In particular, the Gale or Klaus models can be used. They're very detailed questionnaires that take into account those things that we talked about earlier, like age of menarche, age of menopause, and then they also take a detailed family history. And it allows you to compare your personal risk compared to average women your age. So like general population with no risk factors being a 12.6 lifetime risk of breast cancer. If you put your information into one of these models and it comes out with an elevated risk, sometimes that allows us to then stratify you into a different screening protocol that may be more than just your every year or 2-year mammograms and breast exam, but may also include ultrasounds or MRIs for women who are at particularly high risk. One thing also that I just wanted to touch on with this was that there are also the hereditary breast cancer genes, particularly the BRCA genes are the ones that we think of most commonly. Women who have a very strong family history or a family history on one side, or a family history of someone who is diagnosed very young or with a triple negative breast cancer, or if you start to see other cancers, ovarian, melanomas, those sorts of things kind of go in line with that. And so it's always good to bring that up with your doctor, and so that we can just find out if you are qualify for BRCA gene testing, because that also helps us know if you would be a candidate for increased screening and some of the preventive methods that we can do. If someone has in your family has breast cancer diagnosed at a young age, it's always a good idea to ask them, were they tested for BRCA? If they were tested and they were BRCA negative, then while your familial risk is higher than someone who didn't have that family history, your genetic risk from that actual gene would still be low. And when we know that someone does have a BRCA gene mutation, it's helpful for us to actually know the exact mutation, because that's what is going to be passed along from person to person, so we can be more specific in our testing if we're going to offer you testing. When to start screening, there's some slight variation amongst the different groups that provide guidelines. In general, it's kind of starting somewhere between 40 and 49. American College of OBGYN encourages us to counsel our patients, assess their family risk, and to have a discussion about starting sometime in that time frame. The American Cancer Society recommends starting at age 45, whereas the National Comprehensive Cancer Institute or Network recommends starting at age 40, so kind of the most conservative. The U.S. Preventive Task Force Services came out and said if they haven't already started by age 50, you should start at age 50. And then the frequency also varies by these different societies as to whether that's annual or biannual, up to age 55, for up to age 55. When to stop screening also is somewhat kind of varies from society to society. In general, we recommend continuing through age 75, and then to have a conversation with your physician and assess your health status to decide whether or not continuing to screen for breast cancer would be helpful based on your predicted longevity. So someone who's very healthy and good condition and has no other health problems at age 75, certainly it would be very reasonable to continue screening. Someone who has multiple medical problems, it may not be worth the additional time and other risk factors to continue screening at that point, just because the risk of breast cancer is lower in that situation or being meaningful. The American Cancer Society says when your life expectancy is less than 10 years. Obviously, none of us have a perfect magical crystal ball to know exactly when that is, and so that's why it really is a discussion to have with your provider and your own kind of personal feelings about it. Benefits of screening. Really, especially for that younger group, the groups that make recommendations for starting between 40 and 45 are really kind of looking at this earlier detection, because there are better survival rates and less invasive treatments available if we find that breast cancer earlier. Women are less likely to be diagnosed with a breast cancer between 40 and 45, but when you find it, it's usually earlier stage. There also has been demonstrated decreased in breast cancer specific mortality, meaning death and disease burden for all age groups, 40 to 74, but the biggest reduction was for women between 40 and 50, and then again 50 and 60. Some of the risks of screening. So kind of, if it's so great, why don't we screen everyone starting at 40? Or why did some people say start at 45 or start at age 50? Some of the risks include the false positive tests, and it takes into consideration kind of the the personal anxiety and stress, how someone might feel getting a false positive results, the psychological stress of that, as well as the financial cost of follow-up testing, because while annual mammograms starting at age 40 are considered preventative screening by your health insurance, if you end up having to go back for a second follow-up test, that secondary testing often is not covered. So that cost definitely comes into play, especially as our insurance companies shift more of the burden for the coverage of diagnostic testing and all things onto the insurance, onto the patient. The other concern that's talked about is overdiagnosis and overtreatment. There is this idea that maybe we're finding some cancers that would not have become symptomatic, meaning that they're abnormal cells, but maybe these confined ductal carcinomas in situ, maybe they never would have become malignant or invasive cancers. It's really hard because when you find a cancer, you don't know if that's one that's going to become malignant or not. So there's a lot of debate about whether this is a real thing or not, and I leave that to the cancer geneticists, but that certainly is something that the breast cancer groups are talking about. And then the other thing that people often bring up is the radiation exposure. And by far, studies have really shown that the radiation exposure from mammography is very small, and that the benefits of early detection outweigh any risks of any possible mammography-induced breast cancers, and that those really haven't been shown to be significant. So breast self-awareness includes kind of multiple aspects. In addition to knowing your family history, kind of assessing your own personal risk, getting screened with breast exams as well as imaging when that becomes appropriate. It also is knowing and becoming familiar with your own appearance and feel of your breast tissue. They've moved away from the monthly breast exam that I think a lot of us remember being encouraged to counsel our patients and being encouraged to do, because they found that they weren't actually very helpful. Many women were coming to clinicians with concerns about their breasts, and then a lot of unnecessary testing was being done because of that. So they kind of moved away from the formal do your breast exam every month, self-breast exam every month, to more this idea of just being aware of your own normal. That being said, I think it's not to discount the importance of being aware and doing your own exams, because approximately 50% of cancers in women greater than 50 and even more in women younger are actually detected by the women themselves. So mammography and screening the goal is to detect microscopic cancers, so cancers that aren't visible, but often when women that are diagnosed are actually coming to their provider with a lump or with a symptom that they themselves have found. A little bit about the different kind of imaging screening modalities that we have. There's digital mammogram, which is the screening tool for all women, has been the standard. It involves a camera unit and with an X-ray beam and compression of the breast into a 2D image on a plate there. It basically compresses the breast into 2 dimensions so that then we can look through that. Additionally, if you have a mammogram, or if you're very young, if you find a lump in a mammogram, or if you're very young, often we'll use breast ultrasounds. These can be used in conjunction for women who have a palpable mass. So some masses you can see, you can actually feel, but would not be able to be seen on a mammogram, particularly if there's something like a cyst. And an ultrasound would be helpful to be able to better characterize that. Is it fluid-filled? Is it solid? Is there something that we can see on the mammogram, but then when we look with the ultrasound, we don't actually see anything there? So that's kind of where breast ultrasound is. And because of the increased density of breast tissue in young women, particularly women younger than 40, often if you have a concern, we'll start with an ultrasound first, because mammograms are not as helpful with that dense breast tissue. Then MRI. MRI is more so used for women who have very high lifetime chances of getting breast cancer by familial or genetic risks, either something that's been calculated by a Gale model, the Klaus model, or if they have a known BRCA1 or 2 gene mutation, Leaf-Raumani or Cowden syndrome. Mammograms in this setting are generally performed annually, but you're alternating every 6 months mammogram, MRI. So every 6 months you're having some imaging in addition to a clinical breast exam with a provider, who would be either your breast surgeon or your OBGYN or primary care provider. And then there's the 3D mammogram or tomosynthesis, which we actually have now here at Barton, which I think is a great addition and something that we can provide for our community. It's essentially very similar to a mammogram, but it creates a 3D image of the breast, so you get a more comprehensive view of all of the breast tissue rather than just that 2D image. It takes multiple small slices through the breast, so the radiologist is able to review that image, and if they see a density, can actually kind of take it slice by slice to see if that's something when they change the angle, if that's really there or not. So it's more sensitive for picking up cancers than traditional mammogram. It also is better, has lower false positive rates for young women and women with higher density breast tissue. I think in the future, most likely, everyone will be moving towards the 3D mammogram with tomosynthesis because it has those decreased callbacks and false positive rates and better detection. And the radiation exposure, because of the kind of basically program that they're able to put into the machine, becomes very similar to traditional 2D mammogram, so no additional risk with that. There's some signs and symptoms to look out for, things that you would always want to bring to your clinician's attention if you found a palpable lump, particularly one that doesn't go away after your menses pass, so if it's there throughout an entire menstrual cycle and hasn't resolved. If you have area pulled in over the nipple skin, dimpling, anything that kind of talk about this peau d'orange, which is a very indicative of a rare type of cancer called inflammatory breast cancer, but certainly if you notice that nipple discharge that isn't just clear or milky, if it's green or blood color, definitely want to bring that to our attention. Redness or rash of the breast, and then any other skin changes that you might notice. So in summary, breast cancer is really common. Average lifetime risk for anyone in the general population is about 13%. It's important to assess your own personal risk by using Gale model or tools, other such risk assessment tools. Ask your family members, get a more detailed family history if you can, and asking things about, when were they diagnosed? Did they have a recurrence? Did they have BRCA gene testing? The more information we can gather to have a detailed genetic history, the better we'll be able to counsel you. Do what you can to reduce your modifiable risk factors. Don't smoke, limit alcohol consumption, have a healthy diet lifestyle. It benefits you in many ways. Consider breastfeeding. Having a breast exam every 1 to 3 years, starting at age 25. And consider starting mammogram screening between age 40 and 50, and then mammograms every 1 to 2 years. And talk to us, okay? Sorry, I talk really fast. Does anyone have any questions? Yeah.
That Gale model and class model questionnaire thing, is that free, or where do you find that at?
So the Gale model you can actually do online through, I think even cancer.org has it available. There are some, like the Tyrer-Cusick model, you actually have to download to your computer. So if someone is interested in going through that, or we identify they have a high-risk family history, we'll actually set up a separate appointment to go through and get all that information to plug it into that calculation. But the Gale model is available online just by Googling. Yeah. Mm-hmm.
How do you know, or can you identify, is it after a mammogram that you find that out, or is it?
Yeah, so that's a good question. Generally, it is after a mammogram. So you wouldn't necessarily know that you have dense breast tissue until you get your mammogram and you get that report that says, dense breast tissue, may not be able to identify all lesions, which doesn't feel great to get that report, but it's just kind of, one of the things that identify that, this isn't, if you have a mammogram, and I think that's what's really important too, is if you have a lump or you have a concern, you're having persistent breast pain, and you have normal imaging, that doesn't necessarily mean we stop there. So if you're continuing to have symptoms despite a normal mammogram, it's important to continue to pursue that workup, because sometimes things can be missed. Yep.
I'm kind of interested in the genetic testing. Now that a lot of people are participating in 23andMe and the Helix,
Mm-hmm.
Are you finding that more people are coming out with the BRCA1 and 2 and doing interventions, such as early mastectomy?
You know, I haven't actually seen that many people who have come to me with BRCA gene testing through 23andMe. And here and also in the Bay Area, I think we're still kind of on the cusp of that. I think one of the important things to keep in mind is that 23andMe and and the other kind of more commercially available genetic testing is not necessarily the same or as good as doing BRCA testing through other products, because these companies are creating data banks of known mutations within these genes. And unfortunately, there's not just one BRCA gene mutation. There are a whole host of changes in our genetic code that may confer a pathologic or non-pathologic variant. So you can get sometimes where there's a change in your DNA in that gene, but we don't know, is that linked to breast cancer or not? And one of the hard things is that because there's this proprietary system, they're not talking to each other. And so they're not sharing with other companies these variants that they find necessarily. So it may not be as thorough to go through 23andMe as it might through other companies that have a more extensive bank. And that's kind of one of the rubs of where we find innovation in science, and the private sector is really great because they have a lot of money and they have a lot of resources to throw at developing these things. But then when it comes to actual clinical application to patients, sometimes those proprietary priorities kind of do hinder that. So, yeah.
Do they recommend genetic testing in men, a first-degree family member?
If you have a male breast cancer, so if someone has a male breast cancer or has a known BRCA gene mutation, then yes, definitely. Men also are at risk. And a male breast cancer is something that you take very seriously in your family history, and a person would qualify for BRCA gene testing. Yeah?
Does the incidence of gynecomastia in males increase your odds of having the breast cancer as a male?
You know, I'm actually not sure about that. I would have to look that up. I don't know, sorry. I would think just by having more breast tissue, I would think yes, but like I said, I'm not sure. I'd have to look that up. All right. Okay, thank you.